So welcome back at our Cure and Curiosity table. Thank you very much. You're talking about something that really intrigued me when we were discussing this session. Precision medicine. It sounds so elegant, eloquent, and nice, but I always prefer to take a little bit the abstract aspect out of the word, because we have so many individuals listening to us, different nationalities, different backgrounds. So words can be very fascinating and interpreted in a different way. So I would really like you to go a little bit deeper into precision medicine.
The way I would describe it is, as you alluded to, a much more elegant way for the healthcare community to not only assess, but begin to address the actual problems that people are encountered with, meaning that I often use the oncology community as a great example of a very forward-thinking community that very early on they realized that screening was an extremely important part of not only the identification of the disease process, but then follow that up with imaging that allowed them to begin the staging process. And then when they incorporated the components of genetic assessments, is really when I think the tide began to turn. So as in the past, using certain anti-chemotherapeutic agents was more of a kind of systemic, generic type utilization, they were limited in the drugs they had. So they caused a lot of side effects. The dosages were really high. There's a whole field now called cardio-oncology that had to deal with a lot of the emergence of cardiovascular disease because of those side effects. But they did a remarkable job in precisely identifying genetic issues. People are very common with, for example, the BRCA gene for breast cancer, gained a lot of notoriety for a multitude of reasons. But now, utilizing genetics, they have now been able to develop pharmaceuticals to target that specific mutation or causation of why that patient has not only developed, but is suffering from their condition. So as the cardiology community now has begun to mimic kind of that path, we are starting to enter a really exciting time for us where we now, I think, are able to take the blinders off to a large extent, identify the source of people's issues, and now cater therapeutics, pharmaceuticals, devices, specifically to address not only patients' genetic predisposition, but potential, conditions they develop because of that.
So when you were particularly going into the genetic test, do you have something like, I'm a visual person. Do you have something where you can show to us on how that looks like, this kind of tests, and how you actually perform the tests?
Sure. Yeah. No, I think I can do that. I definitely have a pictorial that will be very helpful. As always, as I'm listening to you, my mind is going, and I'm not sure you remember, but genetics is a little bit of a scary thing for most people, because as with any amazing advancement or technology, there's only two sides to the coin, right? The good and the evil. They both exist, often, in parallel with one another. I'm not sure if you remember, I think it was back in the 80s or the early 90s. I read it in the New York Times, but I think it was a physician or a PhD, Ian Wilmot. I think he was Scottish or English, possibly even Irish. That is an important distinction, by the way, so I don't want anybody to get upset with me. But he had cloned a sheep. The sheep's name was Dolly. Do you remember that at all? Yeah. Go back and look at it. I think it was in the 1990s, early 90s. So he actually cloned a sheep.
Yeah, we should probably put a link into this episode that directs it to Dolly.
Yeah, Dolly. And then that was the name of the sheep.
Dolly.com.
So you can only imagine, the advancements that we're not even possibly aware of that have gone on since then. We're focused mainly on the healthcare kind of aspect of things. But so genetics is not something new. Once we had decoded the genome, a lot of things have transpired since then. Before we get to the pictorial, I think it's really important for people to understand that when we're testing your genes, all it's doing is allowing us to truly understand who you are. I mean, our genes, whether it be DNA, RNA, when we're talking about nucleic acids, right? We're talking about, and people who love computers and AI and things like this, right? This is the programming, right? Genetics and genes are the programming and the blueprint for who we are, right? I mean, and that's why you can make woolly mammoth mice now. I'm not sure if you've seen that either, right? So they've taken the code of the woolly mammoth mice. So you can pull literally prehistoric genetics and bring them into the 21st century. So from a cardiovascular perspective, the reason why it becomes so compelling, in one of our former episodes, we discussed lipoprotein(a). There are lots of different types of people who develop high cholesterol. Some are truly genetic, meaning monogenic, meaning that your grandmother had very high cholesterol and was diagnosed when she was 30, had a heart attack at 40. Her mother, your mother, subsequently had the same issue. Now here you are, you're 30 years old, you had your first heart attack. So those are more.
Thank you.
I hope not, and clearly not. But more the monogenic variety, meaning that you were born at birth, your cards were dealt, somebody else gave them to you of no fault of your own. And now you have this compelling genetic predisposition to not be able to metabolize cholesterol, where it becomes a detriment to your metabolic system and results in early events. And then there's this other swath of patients, probably the more common one, which are the polygenics, meaning that there are a number of potential susceptibilities that can either be present at birth, manifest later on, or influenced by environment, right? And things of that nature. The easiest environmental exposure is diet, right? So that's always the conversation where it starts, right? So before we even get into this advanced therapeutic genomic nonsense, right, which is really important, let's talk about the one thing that causes most high cholesterol. Yes.
Yeah, that we can influence.
We can influence. And so talking about nutrition is where it all starts, because most patients that I see, it's a self-inflicted wound. That's how we describe it, right? How many self-inflicted wounds you have. We can't control your genes at this point. One day we will. For now, we cannot. CRISPR, right, is going to be addressing all that as the future rolls on. But the reality is what you can control as a human being is what you stick in your mouth, right? So that's an important piece of this puzzle. So once we've separated that component, then who's left? Because understanding why someone's cholesterol is high matters so much, because you need to understand the mechanism that's causing the problem. Because if the drug you're giving, for example, a statin, does not target the mechanism, then that drug is not going to provide any protection to you. I'll give you a statistic, right? So interventional cardiology, very germane to my practice, treating heart attack patients in the middle of the night. Having done this for 25 years, almost 30 years, treating those patients, we know that anywhere, depending on the data that you look at, that upwards of 50 to 75% of patients that present with a heart attack, guess what their cholesterol levels are? Normal.
I was about to say probably not elevated.
No, they would not fall into the guideline, arena of where we would normally have treated that person. So then if cholesterol, right, which everybody has been taught is the purveyor of all bad things in this healthcare world, why do most of the patients that come in with a heart attack not have high cholesterol, right? So to me, cholesterol has always been one piece of an exceptionally large puzzle. So that's why it's so important to understand, because sometimes the mechanism for why someone has cholesterol that's elevated is not dietary. It's because they don't have a receptor or make enough receptors to withdraw cholesterol into the liver cell to be metabolized. In the last 15 years, we've identified a protein called PCSK9. That protein actually targets the LDL receptor, right? And when that LDL receptor with the cholesterol particle gets engulfed into the hepatocyte or the liver cell, that protein targets that entire receptor and the particle to die. So it gets obliterated. So those receptors, which are normally recycled to get more cholesterol.
Body can be so smart.
It's insanity, right?
Yeah.
So that receptor normally in a normal person goes back. It recycles, right? Cholesterol particle metabolized in the cell, receptor recycled. This protein actually targets the receptor and the particle for death, so it never returns to the surface. We need to understand that. These are genetic conditions that people have. So we have different drugs now, that can target these things. And specifically with lipoprotein(a), we're in the process of developing those drugs. But to your point, and sorry to digress.
Yeah, but I mean, as you said, blueprint, every human is super individual, outside and inside. It totally echoes to me that how important it is. So let's look at.
Yeah, so we're doing this very commonly now. after we've done the entry level, right? So we've done the entry level, we've done the lifestyle modifications and nutritions, we've identified people who are at much greater risk. And sometimes I'll literally have a physical fitness professional or an athlete or a marathon runner in front of me who had a heart attack and had normal cholesterol, right? And they basically try to outrun their genetics. And it just doesn't work that way. And then we bring them in and we start doing more intensive precision analysis to identify what the problem may be. So this is just an example of a very simple test that literally takes 5 minutes in your office. So it's a genetic test where we do a swab of the inside of the gums and the cheek, and we send that information off to a very sophisticated lab. This specifically is called GenEncode, is the company that we're using, based out of San Francisco, with some ridiculously intelligent people that have provided me a lot of insight into.
It means if you go that far from east to west to analyze, then they must be awesome.
Yeah, they do something really special. Yeah. So this is kind of the result that we get back, and just to kind of show you a little bit about what this means. So avoid the colors, which always bring attention. So to what we were just discussing, we initially talk about this monogenic, the people who are destined from a genetic perspective at birth to have these conditions that place substantial risk. So these are the different types of analyses that are done. They're looking at the receptor of the LDL, these ApoB particles, they're looking at the PCSK9 and so forth. So all of the most common reasons why people have a genetic predisposition and development of high cholesterol that lead to cardiovascular.
So for everyone who looks at this, when all these abbreviations, we don't need to dissect them, but they are like, how are they constructed? Just simply said, like LDLR, ApoB, PCSK9.
Yeah, so LDLR, for example, stands for low density lipoprotein receptor.
Okay, so they all have a particular, and then that's the abbreviation. So for people that are very interested, they can probably
you could just type that in line. ChatGPT will give you a wonderful explanation of exactly what that is. The other one
with you, call you, visit you,
I'd be happy to share. The additional ones are the ones where we talk about these polygenic, that are the wider swath of patients that we encounter. And then what it does after the genetic analysis, based on all the information we currently have available, then the patient is placed and categorized into a risk. So for example, this patient that we analyzed not too long ago, we first found out that, most importantly, despite our concerns, the patient did not have a familial monogenic risk. Wonderful, not detected, okay? That eliminates us having to worry about that. Then we move on to what's called the polygenic hypercholesterolemia, which means there's more than one thing at play here. And this is where it gets ridiculously far, right? So this is where I'm going to stop for a second. So because, again, I'm not a geneticist by any stroke of the imagination. I will tell you that when I went to medical school, my genetic book was paper thin, like your piece of paper here with your questions, because that's how little we knew. That's how old I am. When you go to medical school now, the book is like this thick, because it truly is a field, has emerged in and of itself, in isolation of everything else, right? Even though it has everything to do with what we do. So things have changed so much. But just from my basic training and understanding, when we talk about these patients, probably the most compelling thing is something called SNPs. SNPs are single nucleotide polymorphisms, almost a form of mutation. And what they are, to not kind of, over kind of explain it so people understand. Remembering this genetic sequence, remember, let's say you have a gene that codes for the word apple, A-P-P-L-E. But then that person was predetermined to have a genetic mutation at some point in time that altered one gene in that sequence. And now the word apple is spelled A-P-P-L-L. Okay, that one single SNP or mutation now has coded that individual. Instead of doing what it's supposed to do when it was apple, now it's doing something different that's not allowing that person to metabolize. So that's the oversimplified version of how these mutations now begin to alter a person's metabolic ability to kind of challenge themselves with the management of hyperlipidemia. So to me, that's an extremely important component. And again, there are a lot of other things that go into this. And then we kind of go through this analysis, and it gives you the results, and it tells you specifically in granular detail. But most importantly, at the end of the day, what it does, it gives you ultimately this graphic, which tells you as a person, now you, the patient, who have never had a heart attack, never had a stroke, for example, but had some concerns about cholesterol and things of that nature. They gave you the LDL big fluffy particle analysis, right? And they want to treat you. Well, we're going to throw in a calcium score. We're going to throw in some other assessments, but this genetic assessment now allows me to place you along a graphic which tells us your risk. Are you a low genetic risk for a cardiovascular event? Are you intermediate or high? Why this is important, it doesn't mean that every person needs to be treated, but everybody has to make that decision for themselves, equipped with the information that not only what's happening to them now is now fully explained, but now they need to understand that because of that, this is not a guarantee that you're going to have a heart attack, but you need to start thinking about how you're living your life, how we intervene, not only with diet and nutrition, but also with potential pharmaceuticals, et cetera, and how you limit your self-inflicted wounds, meaning you're not smoking, you're not living a lifestyle that ends up developing prediabetes or diabetes. So this for us has changed the landscape. And the beautiful thing is that this genetic profile also now allows us to pick a medication because we have more than statins. We have other medications now, that can be utilized to target, but we wouldn't be able to do that if we didn't know what the heck was going on. So
in these days where we want to know everything, that is probably knowledge that is hard to take if you're a risk taker or if you have a higher risk. How is the healthcare system in the US supporting this kind of test?
Yeah, as everything, it's usually the last to evolve. It lags behind the actual advancement of the science. And usually because these tests tend to be a little bit more on the expensive side to conduct. You can imagine the level of sophistication that goes into analyzing at a granular level all the genetic potential mutations that an individual can have. They're expensive. With that being said, the reason I love this company in particular is they function more at the level of the value that they're providing is their overarching goal. So we usually work with them, who then work with the insurance companies. Ironically enough, some do pay, some will cover. And if, let's say, you have a patient that has an out-of-pocket expenditure, they're willing to work with those people to minimize the damage in a manner that, for me, it's a lot easier to say to a person, look, it's probably going to cost you, and I'm just throwing this out there, let's say $400. It's a lot of money. Most people don't just have $400 sitting around to pay for it. The two things I say, number one, it's a one-time test. A test that changes the entire understanding of who you are, what your risk is, and $400 may save you $400,000 in the next 6 months. Versus the company.
That makes me take a deep breath.
Yeah, right. I mean, you have to ask yourself. I mean, think of the things that people spend money on. Yeah. If you just went through your phone and disconnected from all the silly apps that you pay $10.99 with a month, right? Again, I'm not being...
It hurts.
It hurts, right? But when you actually look at it, the reality is a test that can save your life versus stuff that you're acquiring and consuming that, if anything, I would argue is more detrimental to your life. So people have to start picking and choosing, like, what is your life really all about? So for me, one-time test, some people can't afford it. This company is wonderful in the sense, like I said, they'll work with you with a payment plan to ensure that you can do it where it's not going to, cost you your life. And medicine never should, right? So the conduct of what we do and the patient being first should always be at the forefront, where a patient should not go bankrupt trying to understand what's going to happen to them in the next 5 years, right? That should just be a given. But the beautiful thing about this is, even though we're talking about this now and the patients that I'm seeing in my office, this is going to be at birth, right? So one day there will come a point in time, I hope it's in my lifetime, then when someone's child is born, they stick them for everything anyway, right? They do a little finger stick, the baby's crying, they stick the foot, and you're getting all these analyses, right? What's going to be part of that analysis is going to be your genetic profile, right? And they're going to be able to sequence your genetic profile almost instantaneously, let you know every potential susceptibility you need to be aware of. What are the potential contributing factors? What do you have to avoid? What can you not control? And what can CRISPR do now to kind of slice out that gene and make it all better?
Yeah,
right?
And parents can help right at the get-go on day one, that this child is maybe dancing in a particular way through life that is making it long-term much more easy.
Possibilities are endless, but just think of a world where you can identify. So when you talk about cure, again, and that's that whole cure and curiosity again, it's prevention. The only way you can prevent is if you know. If you don't know. And so for me, this is where we are now. And that's why I get so ridiculously excited about this, because I feel like, thank God, I'm still a part of this very amazing experiment that we're going through, that I know in 10 years from now, the world is going to be a completely different place when it comes to healthcare. And thank God you won't need somebody like me to do a heart attack.
You've been part of this change. You've been part of this change.
Thank
you so much. Thank you so much. And I think it's so valuable that you invested time to give insights to this. And that's that. I'm so much looking forward to come back at our table.
As always, thanks again.